All right, hey guys, today we're going to talk about the stages of lipedema, types of lipedema, what happens to the skin, a very common question we get asked, and we can't answer what happens to the skin without talking about the stages and types of lipedema and where patients are starting from, because the skin is going to react to where the patients are in their journey. And where they are in their journey, it depends on, are they massive weight loss patients? Are they stage 4 patients? Are they stage 1? Are they 20 years old? Or they are 70 years old? So all that kind of is like part of the equation. So I'm going to have here kind of write your questions below and we will kind of go at it. And there's a lot of questions we got asked that I have them here that I'm going to address. Perfect. Now let me pin it. And we can keep going here. Awesome. All right, so the main thing we want to address today is skin, what happens to the skin, how are we able to do it with preserving the lymphatics? That's a common question we get asked. The different types and the different stages and how can I tell? A lot of times like, okay, well, if I do this, what's going to happen to the thigh skin in my area? We'll talk a little bit about arms and we're going to talk how we're able to get these consistent results. So first, as a general overview, all the patients behind us, these are our actual patients, the patients that we've done. So we'll start with here. This is stage 1. That's how stage 1 looks like. Stage 2, stage 3, and then you have stage 4. And kind of like, let me kind of move around. That's kind of like typical what a stage 4 is. So the skin on a stage 4, it's going to be very different than the draping skin on stage 1. And then you have stage 2 and 3 in between. So let's say somebody who's stage 4, massive weight loss, age 60 to 70, we're taking 15-20 liters of fat, lipedema fat from that area. That skin is going to be totally different than somebody in their 20s, stage 1, no massive weight loss. And that's kind of like, you know, the extremes, right? So 20, very young, good collagen. The stage 1, those patients, their skin, the chances of skin resection is almost 0, right? You go all the way to the other side, somebody who's 50, 60, 70, stage 4, massive weight loss. After you finish, if they want the skin to be tight, they're gonna need skin resection. And then you have most people who are kind of in between 40 to 60, stage 2 to 3. Unfortunately, most patients fall in that category. Now, the key is early treatment, because like all patients here is, you know, she knew about it. She's lucky. She knew about it early on. She kind of found us. Treat it early, then it doesn't progress to stage 2, stage 3, and then ultimately stage 4. Our amazing patient here, she didn't know about it. I mean, she did tons of research until she found us, but she found us when she was at stage 4. Unfortunately, 20 years ago, like we didn't exist, this treatment didn't exist, so like patients didn't know about it. So they got like abused their entire life to get to that point. Most of our patients we see kind of like fall kind of within their 40 to 60 years old, around perimenopause. They had one child or 2 kids, depending on what they have. And they kind of like, I'll say about 60 to 70%, they kind of present in that stages. So I'm like, treat it early. If you're before menopause, treat it then. The earlier the treatment, the better. Because when you advance to stage 4, many things happen. One, the knees. Most patients in that when they get to that level, the knee, they start having, as you can see, you see that leg, they kind of like touch here and then they start deviating to the outside. Because we call it kind of like knock knee or valgus deformity, just because of the weight of the lipedema, it starts to affect of the joints and their gait starts to change. They end up with knee replacement. The problem is it's a wear and tear of the knee because of the lipedema. So if they had knee replacement and they didn't fix the lipedema, they're gonna need another knee replacement and another knee replacement. So the key is early treatment, early prevention. Treat that before you do any knee replacement or any other stuff, because the chances of survival of that knee when you're at that level is much better when it's treated before. Now to go back to here, early treatment at stage 1, stage 2, you minimize the chances of progressing to stage 3 and then stage 4. And that's kind of like how we look at it. So to go back and answer the first question is like, what's gonna happen to the skin, right? So for our patient here, I would tell her, okay, when LippyLipo is done and you're done with that, you might be happy with how it's gonna feel. The functionality is gonna be great. In clothing, you're gonna look great because the liposuction is done perfect. But if you want to go out without any clothing, you're gonna have extra skin. So if you want the skin to be tight, then you need skin resection. And you wanna do it at like a year later because the amount of skin redraping, most of the time, knees down, the skin does very well. It's knees up on stage 4, massive weight loss, or advanced stage 3 and massive weight loss, that's where skin resection is gonna be needed. On this stage, they're not gonna be needed as much. So I got a question here, so I'll get the questions as I go, and then I'll keep going to kind of in case people need to bounce out, at least I'm answering that questions sooner than later. So we have Medea here. Can I know what's the proper diet for lipedema patients, please? Should it really be animal-based, products-free? Good question. So there's a lot of discussion about what's the perfect diet for lipedema patients. Different diets work better or worse for different people, but we know certain things that kind of like they make it worse and certain things make it better. So we know sugar is not good for lipedema cells. High carbohydrate diet is not good for lipedema cells, and that's kind of like anything that causes inflammation is just doesn't do. The lipedema cells, they love it and they expand on it. So we know that for sure. Now, what's an anti-inflammatory diet? What does that consist of? Now, some people say keto is great. The problem with keto, it's very hard for patients to stay on it for the rest of their lives. So the being able to stay on it, kind of like being consistent on it, it's for some people it's easy. They're like, oh, when I started keto, I love it. I've been on it for 10 years. It works great for me. But I found this is the minority of our patients. Sometimes they go on it for 1 year, they get tired, and then they kind of go to something else. But low sugar, low carbs, anti-inflammatory works very well with lipedema cells. So, because you want to starve them, you want to keep them at bay. So we know that keto kind of consists of that, it's good. But if you're not compliant, if you cannot do it for the rest of your life, and then you bounce back after a year or two and you go into a high sugar diet or a high carb diet, then it defeats the purpose and then you lose kind of on that side. So you gotta figure out what works for you and you kind of stick to it. As long as that has low sugar, low carbs, anti-inflammation, you're gonna do well. Some people, they do very well, and I'll tell you, just talking to our patients, intermittent fasting, kind of that patients have done well with that. So patients who are doing that, I've seen that they've done good results with that. Keto, fasting intermittently. Now that being said, I've seen patients who like, I've tried it, it didn't work well with me, it messed up with my brain and that. So different people, again, it kind of works different. And so being on the live last week or the last couple of weeks, Dr. Youssef was talking about how like working out on a fasted stomach in patients with lipedema actually kind of like does the opposite effect and increase the cortisol level and kind of, so you really want to know like what works for you or not. And talking about that, tomorrow at 12 we're actually going live with Dr. Bika from Brazil. She wrote so many books about lipedema and hormones and hormone replacement. So make sure you join us tomorrow if you want to talk about menopause, HRT, all that stuff. Cannot wait to see her perspective, kind of how she looks at it, and just kind of like even learn on a personal level. So that's gonna be exciting. Okay, so Media saying thank you so much. Really appreciate all the love you give to your patients, Doc. I love it. I mean, I'm very blessed to be here. I'm very blessed with our patients. I mean, it's just like, it's a joy. It really is. And I think I was born to be on this planet just to do that. Because I mean, I do it with just pure love. Randy is asking, is it best to lose as much weight as possible before having this procedure? You know, that's a great question. So you have regular fat and you have lipedema fat, okay? Now, somebody who has, with weight loss, you cannot lose normal lipedema fat. You can keep them at bay, but lipedema fat is resistant to diet and exercise, weight loss surgery, GLP-1 agonists, or the new generation weight loss medication. But regular fat is not. So you want to drop your regular fat as much as possible. Now, that being said, let's say our stage 1 patient here. Whether she loses or she doesn't, it doesn't affect what we're gonna do, because even if she has some regular fat, we'd still take it out when we do the liposuction, when we're doing her LippyLipos, because she's not gonna max out at the 5 liter. She's gonna max out is at the ultimate residual outcome, because we're gonna stop when she's cosmetically looking great, and we're gonna stop when we maximize her numbing medications, right? It's not the 5 liters on her. Now, let's fast forward to a stage 4 patient. On our patient here, it's like, if you can lose as much regular fat as possible, that's gonna help. And why is that? Because we know she's gonna max out at the 5 liters, and we know she's gonna need many sessions to get her where she needs to get. So on a patient who's stage 4, definitely you wanna drop it as much as possible, because you minimize the amount of sessions that you're gonna need to get to the final outcome. And then you have most people who are kind of like between stage 1 and 2. Like our patient here, you can tell already she lost weight just from the laxity she has. So she lost weight before her lipedema being treated, right? So you know she's gonna have skin resection in the future, but she still has the lipedema, right? So all this is lipedema on her. So she's done the work, because otherwise if she hasn't, then she would need more sessions than somebody who didn't. But let's say she was stage 1 or stage 2, like our patient here, then she doesn't, I mean, obviously if you can do it, of course, it's very helpful, but some people, especially with lipedema, the patients hit a plateau and it's like almost impossible to drop on that scale. I mean, it's just impossible. They do, like, they work out every day, twice a day, they starve themselves, they do all that stuff, and they just hit that plateau. So us telling them, it's like, hey, you gotta lose weight, you gotta do that, it's just, it doesn't help. It actually makes it worse psychologically. So you gotta figure out, you know, the right answer is yes, but also we have to see where the patients are, what they've done, where they stand, how much regular fat versus how much lipedema fat. It's very personal. I think taking that approach where like, yes, you gotta do it to be able to do this, and then it's just not, it's not reasonable. Every person is different, everybody is different, and kind of gotta see what where they are, and you know, if they done the best they can and that's where they are, that's it. I think asking that person to drop more weight and this is like psychological abuse, because they're like, listen, I've done this, I've done that, I've done this, I've done all the stuff that you guys are mentioning, and that's it. I'm done. I can't go anymore. No, you gotta do more. That means they are insufficient. That means they are failing. They're not. I mean, they're actually doing a great job to keep it, like our patient here, to keep it at that level, like she's awesome. Because otherwise she'd be stage 4 and then ultimately she can't even walk. Like our patient here, stage 4, if she wasn't aggressive and getting to treat it, guess what? In the next 5 years, she won't be able to walk. She won't be able to enjoy her retirement. She won't be able to enjoy her time with her husband, her kids, her grandkids. So that's actually very strong to be able to get to this point, get the treatment done, and kind of move on with life. So it's very tricky, guys. It's very tricky because what works for certain patients doesn't work for other patients. And I feel in the lipedema world, we tend to, in medicine in general, we tend to generalize, oh, you gotta do A, B, C, D, E, F. Not really, because different lipedema cells are different, the bodies are different, patients are different, the psychology is different. There's so many things that play into it. Siri here is saying, I think she's replying to Medea, there's a podcast with Dr. Herbst. She talks about vegetarian diet. Lipedema women on keto takes about 3 days to kick in, and it may backfire. In my case, that happened. That's great. Thank you for sharing your experience here. That's awesome. And I love that, guys, like how we're helping each other. I love it. And definitely check it out. Medea saying, we'll do for sure. Thank you, Doc. My pleasure. Siri is saying, if people have lipedema surgery, will they gain the weight in other places? That's an amazing question, and it's a very common question. So people, and that's a good question, because it's like, you know, what if I treat the legs? Is it gonna come back in other areas, or it's gonna migrate to other areas? It's not gonna, lipedema cells don't migrate. So when they are treated, they're treated. Now, the question is, will they flare in other areas? What happens? The nice thing about lipedema treatment is once you take the lipedema fat cells out, they're out. Could you have regrowth, overgrowth? Yes, very slim chances. In our experience, we haven't had anyone yet. I'm sure you're gonna have one in a 1,000 as we do thousands of these cases, right? So, but it's so rare. It's like being hit by lightning. Really, it's very rare to get it. It doesn't mean it's zero, it's very rare. Now, what about like, can it come in the arms? What happens is, let's say our patient here, she has it in her arms as well, all right? You treat her legs, and then she goes in, she has kids, goes through menopause, and now she has flare in her arms. It doesn't mean it went from the legs to the arms. It means she's a type 4. She has it in her arms. She was going to flare. She didn't flare on her legs because her legs were treated. She flared on the arms because there is residual lipedema fat cells. Lipedema fat cells are responsive to hormonal changes. Menopause hits, estrogen drops, lipedema fat cells starts to kind of like party together, and then they flare, and that's what happens. So the key is to treat them before those like milestones, right? So you want to treat them before pregnancy, you want to treat them before menopause, you want to treat them before extreme stress, you want to treat them before you're before any GYN surgery, before removing your ovaries. Like all these stuff are crucial, kind of like you're strategic. Treating lipedema is like playing chess. You move one part and different things change at the same time. So you gotta be very smart about it. That's why like it's not a cookie cutter approach. It's not like, and it's hard because patients, they want to see like, okay, what's the best thing and how can I go from A to Z? What's the best thing for you might be really a bad thing for somebody else. So you gotta really know, you go back to that chessboard. So if I, like this patient, let's talk about that. So this patient here, if I treat her legs, and we did her, she looked amazing, right? So treat her legs. Okay, so we treated the legs. Have you have kids? Yes or no? Yes, I have kids. Okay, great. When is menopause coming? Well, menopause coming in 8 years, let's say. Okay, do we have it in the arms? Let's attack the arms before it happens, all right? That's totally different than same patients. Let's say she's 22 years old. Treat the legs. Well, I'm planning on having kids in my late 20s. Great. Do we have the arms? Yes or no? Oh, we've done the arms, we've done the legs, we've done that. Great. Now, we've all treated. Let's keep it at bay. Dietitian, anti-inflammatory, what works for you? How do you stay? Vegetarian diet, keto diet, whatever works to certain people, and then she sticks to it to go through pregnancies and menopause. That's a totally different chess game than our patients here in stage 4. It's very different. Our patient here, what our main goal is functionality. I want her to be, and what is she looking for? To walk, to be mobile, to spend the rest of her life enjoying daily activities, play with kids, play with grandkids, going out. Very different about regrowth and that, post-menopausal, after menopause, we don't have to worry about. It's a totally different chess play here than the chess play here. So the recommendation for that patient is totally different than the recommendation than for our patient here. And I keep on picking on stage 1 and stage 4 because 2 and 3 are kind of in between. Like 3, you're more on this side, 2, you're more on that side, and it's a spectrum. You can go from 1 to 2 to 3 to 4. Early treatment is key. Playing the chess game is key. Where you are, have you optimized what you're doing? And if so, that's it. You gotta go into treating it. You know, like what are you doing? Let's say somebody who's like eating sugar, doing all this stuff, not doing MLDs, not doing compression, and you know, like you gotta start, you know, like you gotta start hitting that versus somebody who is not doing, who's doing all that stuff and they plateaued. The recommendation for that person is very different than the recommendation for this person. So kind of like, it's a very complicated issue, and you have to understand like every piece, how it's playing together, and you gotta connect it. And you gotta see from a surgical standpoint, is like, what is that patient? How can I get them what they're looking for? Is it cosmetic? Is it functional? Or is it both? Cosmetic and functional. How old they are? Are they going into pregnancies? Are they going into menopause? What they're looking to achieve from it? Do they want to do it with, how many sessions are we talking about? Some people, they say, hey, you know what? Like, I just don't have the time or the finances to be able to that. What we can do to just do that and not do that, it's like, that's different. Some people say, hey, listen, I want to be the healthiest possible. I want to enjoy life. I don't care about the finances issues. How can we address it? Then that's a different chess game for that. So it's really like different people are in different stages of life. So we want to figure out where that patient is and come up with a solution for that. And that's the beauty of it. Because every person is different, every person is a challenge, and how we can get them there. And the fact we're only doing one case a day, I can't tell you how important, probably more important than the surgery itself, it's spending that hour and a half in the morning, listening to what the patient is saying and what the patient is looking for. Because that allows us to really get a game plan with that. And during the surgery and all that stuff, it's just like, it's been a game changer. In my opinion, there's no other way of doing it than that. If it's a lipedema case, it's one case per day, and the surgeon has to only do lipedema and not do anything else. And that's how you can guarantee consistent, great results. Any other way, you will get an outcome, but you will not get this outcome. There's no way around. There's no shortcuts in life. I wish there is. There's nothing. And that's coming from a guy who used to do it, general anesthesia, 4 cases a day, 20 cases a week. I mean, like really, like just like, you will get an outcome. But if you really get the most amazing outcome with the best experience, with the best thing possible, you just do lipedema, you just do 1 case a day, you give all your energy and time and passion to just one patient, and that's how you can get the best outcome possible. Good question, Siri here. Naveen is asking, we would like you to come to Middle East or Europe because America visa is hard to get. You know, Naveen, that's a common thing that I get all the time. It's like, hey, we have issues. We cannot get a visa to come for you to do our surgery, or can you come here and there? It breaks my heart because I really want to go and help as many people as possible, but at the same time, our schedule is very booked. Like we probably have like few spots available for next year, and it's first come, first serve. So for me to fly to Europe or the Middle East to do surgeries, that means I have to shut down the practice here so that I can go and deliver those results. If I shut down the practice here, that means the people who are on the schedule, now they are even being delayed further. So, and that's gonna becomes like, what to do? So here, I have all of our patients, they fly to us. They come here, we have the system, I know exactly what things are, what my staff is doing, like Jerry, JC, like everything is like perfect. The setup, the people so it allows me to consistently give a great outcome. So I hope one day I'll have a solution for you. I just don't at this point. I need to figure that out. We are having many surgeons reaching out to try to figure out like how to learn, how to do that stuff. And we're kind of like testing that. So we'll see. We'll keep you posted here. So let's keep on going there. Pico's saying, how about belly area with diastasis recti? That's more of a tummy tuck thing than actual lipedema stuff. With lipedema who have type 1, where it's mainly, we call it like, they have like the tire around the upper buttock area and lower back, and they have like the love handle area. That tire effect, that's lipedema. That you treated with 360-degree liposuction. So this is crucial, right? So that's gonna do that. But for diastasis, for muscle separation, all that stuff, it's not liposuction, it's a tummy tuck with muscle tightening. And we don't do that. We just treat lipedema patients with LippyLipo because of the high demand. I mean, we dedicated our entire practice to just doing that. We got asked almost every day, it's like, hey, can you do this, that? The problem is, if we accept one patient who's not lipedema and we start going down that rabbit hole, I mean, we will be booked probably for the next 20 years. So it's just so that we're very selective on whom we choose on as patients. Isa is saying, is this procedure covered by most insurance? Our practice is not in network with insurance. So, and we haven't been in network for many years. That being said, there are certain physicians and certain practices who do take insurance. My thing with insurance is, the quality. The problem with insurance is the reimbursement is based on how many cases you do a day, right? So if you give a great result, or you give a below average result or a bad result, the reimbursement to the hospital, to the practice, to the physician is exactly the same. So people, the system is made in a way where it reimburses quantity, not quality. My focus is quality. So that's why insurance and we're just like, we're not on the same page. Because when you go to insurance and say, hey, I want to spend 6 hours a day, and I'll spend all day with one patient, and they're going to say, okay, it's not going to work out. So that's the problem. And the issue is, unfortunately, the way the hospitals are run and the insurance companies are run, they are businesses. They are made in a way to make money. And the way to make money is by how much you can do in a day, and how much you can pay and still maintain that profit. And unfortunately, a lot of great physicians are stuck into that, because if they don't reach that quota for the day, or RVU, or whatever they call it in a hospital setting, they're like, they put that person on a blacklist because they're losing money on that person. And now that surgeon's like, man, I want to do the best thing for my patients. Yeah, but you gotta be faster, you gotta be more efficient because the numbers are not working. And so many people in the medical field here, they know exactly what I'm talking about. Now, the problem is no one talks about it. One, they are scared for their jobs. They can get, or from an insurance or from a physician standpoint. And it's just kind of like, they just don't want to talk about it. But I can talk about it because, again, like, I just don't take insurance. So it's kind of like very different. Unfortunately, like, that's how the system is. And who's suffering the most are the lipedema patients. So let's keep on going here. Susanna is asking, did I miss if you already covered how to tell if it's lipedema and regular fat? Good question. So lipedema fat is thick, fibrous, resistant to diet and exercise. You got a tree-trunk appearance. Most like type 3 that kind of goes all the way down to the ankle, but not everyone. Sometimes you've seen it where it stops at that. Regular fat, when you lose weight, you lose that fat. That's regular fat. It's not nodular. So typical lipedema presentation is easy bruising, hypermobile joint, varicose veins, fat resistant to diet and exercise, tree-trunk appearance. It runs in families. Mom on that side, kids, sister, like somebody, aunt, somebody has it in the family. That's usually lipedema. I think that if you want to go back, one of the lives, I talked at length how to differentiate regular fat from lipedema fat. It's like half an hour conversation. Gabby is asking, can it be treated in a teen? That's a great point. The short answer is yes, but I'm very careful about it. We did consult many times. We haven't done it on a teenager in our practice. And I've been very careful about it because it's like a thin line, because it starts at puberty and kind of it gets worse kind of with aging and pregnancy. Now, when you're a teenager, especially if you're underage, mom and dad are making the decision for you. And that's kind of becomes where kind of like, yeah, it's the right thing to do, but would you do it? And then I flip it. I was like, if God forbid that was my daughter, and knowing what I know on lipedema, what would I do? And it takes me down this ethical, kind of like this, that, and I was never able to find a solution for it because there's pros and cons for each one of it. The safest bet is wait until the child is 18 years old and let them make their own decision. Probably that's the safest thing. But what you can do if they are a teenager, especially 13, 14, and you start seeing that, it's affecting it, definitely MLD, compression, and great diet for them. So until they kind of like, because you want to see where they plateau and then treat it at that point. Again, it's a very tricky, very good question, very tough to answer. But I'm very hesitant because of not the procedure, because of the psychological effect on the child, because it can go both ways. It really is. And as a parent, you're like, I don't know. So, and I've had like many discussions with other physicians who they have a daughter who have lipedema, who has lipedema, and kind of like We talked about it, and it's just, I'm always has been more on the conservative side. You know, non-surgical, hit it as much as you can from a non-surgical diet, kind of like have a team, educate the child, information, all that stuff, so that they know what they have. And then once they hit 18, have them make that decision. I think it just saves a lot on the long run. Because the last thing you want to do is like, you know, just make a decision for them and somehow, you know, they're just not happy with it. But again, that's my personal opinion. There's no real data about it. Good question. So let's keep on going here. Brandy is asking, what compression brand do you recommend someone use prior to the procedure? Great question, Brandy. The key thing, so there's like multiple things on compressions. Some patients say this compression is the best. Some people say that compression is the best. It's really what works for you. You want to go with the flat knit, usually are good, but again, they come with their own, like, you know, just more time to do it. This, that is going to take the measurement of that. From having compression is better than not having any compression. The higher the pressure on the compression, the better it's going to be than a low compression. We know that for the fact. You're going to be able also, like, you can use it. Some people have with a clutch in it. Some people doesn't have it. It depends on. So that being said, I'll be very hesitant to recommend one brand or the other. And the reason for that is there's always kickback in the system. Like, we don't live in a vacuum world. So I'm very hesitant not to say one brand or the other or that. We use certain brands and it works very well for patients, but I don't want to endorse anyone. I don't want to do that, because the last thing I want to do is do something for somebody and then kind of like people's like, oh, you know what, if you do this and that, then you got, I'm just not into that part. But I'll say there's a lot of, go to the Global Lipedema Awareness Group. There's tons of great groups on lipedema. Go there and kind of see like what patients are talking about each other and have a patient kind of recommend from their perspective. The problem, guys, is, and you can see, like, I'm not a big kind of like advocate of, like, you know, just recommending certain things in business, because there's so much like things that happen in the back scene that really taking advantage of patients, and I would never ever do that. So you'd never see me kind of like, oh, I mean, I can't tell you how many times like reps and companies and come to us, because we're just well known in the lipedema world, right? We're one of the best in the world to treat lipedema. And they come to us like, hey, if you can do this, or, you know, where they had put our name, or if you can mention it in your live and stuff, and then you will get XYZ, blah, 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 and on the backside. We're like, thank you so much. We just don't do that. So, and that's why you guys, and then I'm saying that, so you know the reason why I just don't go down that road. Siri is saying, invite surgeons from the Middle East to come and watch you and train with you. Again, we got asked a lot. I'm very hesitant. I need to figure out like how to structure up. My worry with that, getting you get the learning curve is so hard with LippyLipo. It's so tough to do. It's like teaching somebody to learn how to play chess. So it's like, okay, I'm gonna go learn chess from the best chess person in the world. When I leave, I'm not gonna have that person's skills. So my worry, somebody's gonna come, they're gonna learn, they're not that good. They start doing LippyLipo in their home country or their homes, whatever they are, and they're gonna get bad results. And now LippyLipo is gonna have a bad branding from it, because that person didn't know how to. It doesn't mean that is bad, it means that person is not good at it. So that's been my hesitancy of like not trying to be more open about it with other surgeons. I do have a few people who come in and kind of like learn and shadows and stuff, but again, they haven't done well because it's very hard to go through that learning curve. And you're not gonna find a single surgeon where they're gonna shut their office and just do one surgery a day. It doesn't work. So they want to do lipedema among other surgeries a day. It doesn't work, and that's what I tell them, because if you're not spending 6 hours, 4 to 6 hours on a case, you're not gonna get a good outcome. You're not. If you're not doing it awake, you're not gonna get a great outcome, because you need the muscle contraction. You need to minimize that. If you're not taking your time, they're not gonna have a good experience. But it's just, again, something gotta give, and that's what usually happens. Gabby is saying, do you recommend to lose weight before getting surgery? We addressed that previously. I'm gonna save the slide, guys, and Gabby, go back to this live afterwards, and I answer that question at length. So I'm gonna skip this question so we go through other questions, but that's a good one. Niveen's asking, what about exosome injection? Does it help? Niveen, I'm going live tomorrow at 12 p.m. Central Time with Dr. Bika from Brazil. She's an endocrinologist, very well known in the field, wrote a lot of chapters about lipedema and what you're asking about. I want you to ask that question tomorrow. Very good here. Versace is asking, where are you, doctor? We're located 1 hour north of Nashville Airport. Mrs. Sky is asking, do you allow or offer payment plans? For those, I will double check with Jerry. We do work with certain companies for that. So the short answer is yes, but I will double check with her kind of what they do on that back end. Demi is asking, do you go to Spain? I don't. I just operate here in the US in our facility. Gabby is saying, thank you, doctor. Do you notice, Jane is saying, do you notice your patients having dry heels in stage 2 and 3? You know what? That's a very good question, and that's an interesting question. We always talk about lipedema, knee pain, bruising, heaviness, swelling. What we don't talk about is actually the effect on the foot itself, like the effect here. We don't talk about that. And I can't tell you how many people, they complain about pain in the foot area, plantar fasciitis in the foot, all these symptoms that results from lipedema, but we don't connect the dots. And I love that you're asking this question here, Jane, because the short answer is yes, there's a lot of symptoms that happen on the foot, even though the lipedema is not in the foot, but the symptoms come from having lipedema. It's no different than having knee replacement because of lipedema. The lipedema caused the knee to go bad, and then the knee going bad results in knee replacement. Same thing on the foot. Peripheral neuropathy, nerve issues. The nerves are fine. It's just the lipedema, the inflammation of the lipedema and the heaviness of the lipedema fat causes that abnormal neuronal study. And that's kind of here. And then you see it in the skin, dry skin. You see that all the time. And I've seen it when I started doing that, patients say, you know what, I feel like after the liposuction, like my skin is peeling off. And I'm like, that's interesting. And then I listen to another patient, and that's the key, guys. I listen, because I learned so much. I learned probably the most I learned from lipedema is from our patients by just listening to them. And then I had another patient, she mentioned the same thing. And then another patient that she mentioned the same thing. It's like, I'm having like dryness, the skin is peeling off. And then they come back a few months later, they I would ask them, like, hey, how's the skin doing? It's like, it's no different than doing retinol on the face. There's regeneration to the skin. So the old skin, because it's healthier, now there's better blood supply, better nutrition to the skin. So the old skin sloughs out, and then you have new skin. So you go from like not having a good skin on the distant, kind of like on the lower extremities and the feet, to kind of having healthier skin just because you have a better environment for that skin to survive. Great point. So the short answer is yes. And my bet and my guess is you're probably asking that probably because you're experiencing it. And let me tell you this, many patients, they share that same thing with you. So you're not the only one. A lot of people, they kind of have that as well. Very good. Jane is asking, also, do spider veins subside on their own after surgery? Another great question. It depends on the cause of the spider vein. Two reasons. One reason, if the valve, that's like valves within the vein, right? If the problem with veins is the valve is not good, like it's not like occluding or stopping the backflow of blood, it's like it's coming kind of to here, not to here, then it doesn't, because that's the problem. That treatment is a vascular surgery treatment. But if the backflow, if the valves are good, but the backflow is from heaviness of lipedema fat preventing the outflow of the blood from the veins back to the heart because of the compression in the thigh and kind of from the heaviness of the lipedema fat, then when we treat lipedema, we see the spider veins get better. Some people have both problems. So our experience have shown that most spider veins get better, not all of them, depending on what the problem is. The ones where the problem is from the heaviness of the lipedema fat, they improve. The ones where the problem is from a valve problem, it's not occluding all the way up, then it's a vein problem, not a lipedema problem, then the treatment is different. But what I tell patients, if you have a vein problem, if you have a spider veins, varicose veins, all that stuff, don't do your vein surgery first. Do your LippyLipo first, because you might not need that. So if you do it the other way around, now you definitely need two procedures. You need the vein procedure and the LippyLipo procedure. But if you do your LippyLipo, you might not need that other procedure. You might still need it, but you might need it less, or you might not need it at all. Excellent. Abram, saying, does LippyLipo reduce knee joint pain and increase mobility range of motion? I haven't been able to squat for over a decade. Great question. So my guess is you're probably into stage 3, 4, because you see that stage 1, usually on stage 1, mobility is usually good to excellent, good to excellent. Stage 2, it's more about good. Stage 3, good to fair. Stage 4, fair to worse. And that's kind of like, and the range of motion goes down. And the reason for that, other than the pain in the knee, other than the wear and tear on the knee, the range of motion goes down because on the calf muscle, you have the fat pad that sits on the calf muscle. And you have a fat pad that sits behind the knee. And when the knee bends, okay, so the back calf muscle, the fat pad, is hitting that fat pad from the back of the knee. So it limits the range of motion of that knee. What happens with our patients when we do the liposuction all the way around the knee, on table, they say, oh my God, I can move my knee better immediately. It's not like it's just magic, it's physics. The fat pad was sitting in the way of the joint movement. So when you take that physical obstruction, which is the lipedema fat pad, from the back of the knee and the back of the calf, now that joint is moving better. When the joint moves better, the function is better. And that's what happens. And again, it ties back. Early treatment is key. Now, unfortunately, some people didn't know about it until now they are stage 4. But treat it now, because if you don't, late stage 4 leads to inability to walk, leads to like really affecting your lifestyle, really kind of like not having good function. And that's where really complications start kind of like becoming high in terms of like not able to walk, higher risk of blood clots, boom, 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 more health problems. So people have a window, I feel like, between, especially if they are after menopause, they have a window between that 60 to 70, even early 70 of like, you just gotta treat it. Because when you wait beyond that, what happens is health, not from a lipedema standpoint, but from a health standpoint, the heart might not be able to tolerate LippyLipo. The lungs might not be able to tolerate that. Or you have other comorbidities, or you're on a blood thinner, and now you cannot get this procedure done. So do it earlier. The sooner you do it, the less the chances. So there is that window. When I see patients, and I'm like, and that's where sometimes we're opening spots for patients like that, where Jerry and I, we sit together, it's like, because I know if we cannot get this patient in, her chances of going really down a bad, kind of like really bad cycle, it's gonna, so we gotta get them in for that window. If we know somebody's gonna go through menopause, we open certain spot and then we move things around. So again, it's a chess game, guys. It really is. And we gotta be very smart how to address each move. Excellent questions. Let's keep on going here. Okay. Heli, how do you manage the skin sagging after liposuction? Great point. Let me show you actually. Let me see if I can, if I have another standing up, kind of like after lipo. Just to, because there's a lot of questions here about before, after, and let me see. So let's do that here. Which one is this one? Okay, well, that's on table. Let me go to something. Okay, that's standing up. Let's do that. So our patient here, answering kind of like, you know, like kind of after, like you kind of see here before, after standing up, the skin is great. Look at that skin. I mean, it's like, you look at here and people are like, oh my God, do you do skin resection or do you do this? Look, it's perfect. She's early on. She's like, probably 2-3 weeks since I still see the bruising, all this bruising. That's very early results. And a lot of people ask us, oh, why don't you send the patient immediately after and all that stuff? One, it's contamination. It takes us 6 hours. I want to get the patients out if possible, and there's a lot of drainage. So I want to kind of keep the field nice and clean and dry. So now I'm having patients send us the pictures like 2-3 weeks after, so people can see how they look like standing up. Because all our results, they look great on table, and people are like, oh, what about 2 weeks after that? And that's a great question, but that's how they look. So if you look over here to go answer your question though, look how tight that skin is in the thigh, because that's what you worry about, in the thigh. Look how tight at the knee, how tight at the calf and ankle. So this skin does very, very well. When you do LippyLipo, you know what you're doing. Again, early stages, stage 1, stage 2, skin's gonna do well. Late stages, stage 3, 4, massive weight loss, bad collagen, then you would need some sort of skin resection in the future. So let's go back to our stages here. And let's go here so that you have that. Yeah, perfect. Okay. So that's kind of from skin. Janine saying, do you, doctor, do you or someone on your team speak Spanish? We don't. That's a good point here. Probably Jerry, usually when she does that, sometimes we use Google Translate, but I will check with her. I'm sure she has a solution for that. Mirna saying, where are your location? With 1 hour north of Nashville Airport. Dr. Vika is here with us. I don't know if you're still on. Guys, she's joining us tomorrow live at 12 p.m. Make sure you attend the live. It's going to be great. She's so smart. She's an endocrinologist. She knows so much about hormones, lipedema. She does talks about it. I cannot wait to pick her brain tomorrow. Super excited for that. I got a question here in Spanish. Let me see if I can. Cellulitis, fibrosis. Maybe she's asking about complication with that. The key is to go to somebody who knows what they're doing. Yes, fibrosis can happen after these surgeries. Stuff can happen. If you go to somebody who knows what they're doing, that's all what they do, you're going to have the best outcome possible with the least amount of cellulitis, fibrosis, all that stuff. Excellent. Let's keep on going. What Brandy is saying, what should someone do to improve elasticity of skin prior to procedure? You know, that's a great question. I think eating healthy, drinking water, all that stuff, working out is helpful because the more muscle you have when you do the lipo, it's going to allow that skin to rehydrate better. Sometimes people take collagen pills. Again, there's no real data about it, whether it helps or it doesn't. That's something that you might want to consider. So all these stuff is really helpful. But really, how the skin is going to do, it really depends on genetics, what stage type you are, at what level you are, especially stages, how old, and whether patients had massive weight loss or not, and how much lipedema fat cells you're taking out. You know, if you're taking so much lipedema fat cells and somebody is a massive weight loss, you're going to need skin resection, and you're stage 4, right? I mean, 100%. If you're stage 1 and no massive weight loss, then the chances of skin resection is almost 0. And then you have people kind of like in between. Great question, Brandy. Ava saying, thank you for your answer. You're welcome. Jane saying, how do you feel about lippy patients taking Ozempic? My doctor won't recognize I have lipedema and just says my BMI says I'm obese and put me on Ozempic, but I plan on doing surgery in the next year. Well, first, I'm sorry that your doctor feels this way. I truly am. Maybe you want to look into having another doctor, but that's a different story. Let's kind of, to answer your question here is, it bothers me, guys, because there's so many people in the medical field despite all the stuff we do, they just still don't believe that lipedema is a thing. They think lipedema is regular fat. And I'm like, it just blows my mind, because you have regular fat and you have lipedema fat. Within lipedema fat, you have multiple different quality of fat. Thick, fibrous, nodular, bloody. I mean, there's like a range of things. You have stage 1, 2, 3, 4, type 1, 2, 3, 4, I mean, 5. I mean, you have all these stuff. It's like an entity by itself. Like, it's probably a book by it, like a huge book by itself, with pathology, diagnosis, all that stuff. And still some people just don't believe in that. And what bothers me, these are actually doctors who know what they're doing and still like they're not open-minded about it. But that's an entire different conversation. To go back to your question is, how do you feel about taking Ozempic? I actually, I had a patient here, I don't know if she's on this live or not, because we used to look at it from 2 different angles, and we keep on changing. So what I like about it, it takes care of the regular fat, especially on somebody who's going to need multiple sessions. It minimizes the amount of session, because we know it it improves regular fat. It has limited effect on the lipedema fat, potentially minimizing progression of lipedema fat. Potentially, we don't know yet, time will tell us. But it has its own side effects. Now, if you're getting that and you're getting lipedema liposuction done under general anesthesia, you need to stop it for at least 2 to 3 weeks. Because the way these drugs work, they work by slowing the GI system. When you slow the GI system, the risk of aspiration, which basically kind of like vomiting during surgery that's under general anesthesia, is high, and people are having complication where the vomit basically goes through the stomach, to the mouth, back to the lungs, and people end up with bad complications. So the anesthesiologists are now saying, if you are on Ozempic and stuff like that, and you're having surgery done, could be lipedema, could be something else, you need to stop it many weeks before your surgery, so that we don't go through this bad complication that can happen if you are on it. Now, so based on those guidelines, we were stopping it on everyone. Now, that being said, we do our cases fully awake. There's no anesthesia, no general anesthesia, no IV sedation, no POC. There's local anesthesia, it's like being at a dentist, but there's no that. So people are eating, are breathing, are talking, they're like normal, they're moving around. So for me now, we're kind of like switching, like, you know what? We probably are leaving our patients on it because it doesn't make a big difference, because they're awake, we're not putting them to sleep. And I had one of our awesome patients, she was asking me, it's like, but I was told that to stop it. And I was like, okay. And I think today she was talking to JC as well. I was like, it really, I don't know if you're here, I'm going to answer your question. It really doesn't matter. If you want to stay on it, I think that's very reasonable. And if you want to stop it, it's also very reasonable. I don't like to change treatments last minute, because that confuses the patient. So if we have like a plan for somebody, we just keep them on that plan. But this is the real answer. From what we do, it doesn't matter. But if somebody else is doing your procedure and you're getting sedation, or you're getting general anesthesia or that, and you cannot really control your GI tract and your respiratory tract, you definitely need to stop it so you don't have the complication from that. Abraham saying, just finished menopause and had a flare and increase in inflammation. So common. That's so common. I have been waiting months to even get an in-person consultation locally. It's frustrating waiting. And that's, first, thank you for sharing. Second, it's so frustrating. I'm frustrated for you because like now they put you into an advanced stage, right? More inflammation, potentially more surgery. So timing is key, guys. Like if you're before menopause, get it done, like what you're doing. Push for it, go to somebody else. Like don't take no for an answer. If that clinic doesn't take you, go to another clinic. Try to find a way of getting it done, because what happens is it's like going through a growth spurt when we're growing. Lipedema does the same. It's like stable, it's like that. Stable, and then growth spurt. And then stable, not totally stable, but like kind of like 20% inclination. Kind of like it's incline, and then growth spurt, and then incline, and then growth spurt. So I would definitely look into that. Maybe that's saying, I'm not sure of my stage, likely 3. Ace saying, I have lipedema as well. Vince is saying, can you tell me details about getting an autoplasty? Autoplasty is ear thinning. We don't do any of those surgeries. All what we do is LippyLipo for lipedema patients. Again, we don't treat non-lipedema because if we take any patients who's not lipedema and we're gonna go down a rabbit hole and we're gonna have our schedule fully booked for years. So that's why we're on purpose not, we just don't treat anyone except for lipedema at this stage. So I'm gonna take this last answer and last question, and then kind of like we'll wrap it up. Jane's saying, how many surgeries would someone like the stage 3 photo need in the lower and the upper legs? So I guess for this one you're asking, I would say 80% chance to not more than 3, not less than 2 to 3. And what dictates whether it's going to be 2 or 3 is the thickness of the bone and the muscle that the patient has. If somebody has wider muscle and bone, then that circumference is made less of lipedema. If they had very thin muscle and bone, then that circumference is made more of lipedema fat cells. So thin muscle and bone, three sessions, thick muscle and bone, 2 sessions. Usually when we're doing the ultrasound the day off, it kind of gives me an idea of the thickness of the lipedema fat cells that they have. All right, guys, I'm gonna wrap it up. Marianne here is asking if we take insurance. I answered this question. I'm gonna save the live if you wanna go back to it and kind of like we talked about insurance and why we are not in network with insurance, but I kind of go in detail with it. Anyhow, guys, I'm gonna let you go now. Tomorrow at 12 p.m. Central Time, going with Dr. Bika live, talk about, she's an endocrinologist. She's gonna discuss all things related to hormonal replacements, medications, all that stuff. Get your questions and we'll see you then. Thank you so much. And we'll see you see you tomorrow and every Monday at 12 p.m. I'm gonna do those lives unless it's like Christmas or New Year, it's like some major holiday. But other than that, we will go live every Monday at 12 p.m. Central Time.